Well, good morning, everyone. My name is Don Sin. I'm a respirologist at St. Paul's Hospital, and I'm delighted to speak to you and with you and carry on this discussion about COVID-19. I'm based here in St. Paul's Hospital in Vancouver, and I will share with you some of the new developments that have happened worldwide as well as more locally at St. Paul's. So I'm going to share my slides and hopefully this will work. Okay, please let me know if you can't hear me or have trouble seeing the screen. Let's start out with some bad news, news that I think you've been exposed to, which is that COVID-19 has become a pandemic affecting more than 180 countries worldwide. And this is a slide showing the cumulative mortality across the world based on countries, and the leading mortality has been observed in the US. Worldwide, COVID-19 has impacted 9.3 million people, accounting for nearly 500,000 deaths. About 20 to 30% of those deaths have occurred in the United States. Canada has been doing fairly well from a global perspective in terms of both the incidence of coronavirus cases and mortality, as shown here. Financially, the COVID-19 has had a tremendous impact on our global economies. One estimate suggests that the total economic impact could exceed $8 trillion. Clinically, I'm a clinician at St. Paul's Hospital. Clinically, most patients present with one of these or two or more of these symptoms, including fever, sputum, shortness of breath, sore throat, headache, chills, nausea and vomiting, and diarrhea. The most common symptom is fever, but not everyone has fever. The fever is a presenting symptom in only 44% of incident cases, meaning that temperature screening is not particularly effective in identifying COVID-19 patients. COVID-19, the virus, is transmitted mostly by respiratory droplets. There is concern that it may also be spread by aerosol, but the primary mode of spread is through respiratory droplets, which are generated during even simple things like speaking, talking, and singing, and so forth. The disease undergoes a stereotypical course. There is an incubation period where patients are asymptomatic. They have the virus, but they're asymptomatic. Hi, John. That lasts for about 5 to 7 days. That's followed by a symptomatic phase where patients have these symptoms, including fever, sputum production, shortness of breath, and so on. Majority, about 80% of the cases, the symptoms subside, the disease goes away. However, in about 20%, patients move to more severe forms of COVID-19. And we call this COVID-19 pneumonia. And it's characterized initially by a hyperinflammatory state. So it's a host response to the virus that is so severe that it makes the patients very sick. And then about 5% of the cases, the disease progresses to a critical stage where patients will require oxygen therapy or mechanical ventilation. And approximately 0.7%, 0.8% of patients will succumb to their disease. So this is the natural course of COVID-19. Overall, the global pandemic has hit the hardest, initially in China, but later has spread to continental Europe, particularly Italy, Spain, and UK. It's also hit United States very hard, especially in the eastern, northeastern border. And now increasingly, South America is being impacted by coronavirus. And this is shown here. The current daily confirmed COVID-19 mortality is now highest in Mexico, South America, and Sweden. Not everyone is impacted by COVID-19 the same way, even if you catch the virus. Most of the deaths occur in individuals with pre-existing medical conditions. The most common being cardiovascular disease, followed by diabetes, chronic respiratory disease, high blood pressure, cancer. So most of the death worldwide have occurred in older individuals with these pre-existing conditions. One question that comes up often is, have we seen a spike in total mortality or total number of deaths during this pandemic, or have we replaced corona deaths with something else? And this is a slide from The Economist where trend lines for mortality across seasons are shown here from 2016 to 2019, and the red line represents 2020 during the pandemic. And when we count total number of deaths, you can see a tremendous spike in 2020 data across from March to where we are today, June, indicating that the death from coronavirus is on top of mortality from other common causes of death. And these are just some examples of countries where this trend can be clearly seen. In Sweden, in Italy, and New York City, you can see the orange bars or lines, which indicate the excess mortality related to COVID-19. We've also learned quite a bit about how to prevent or mitigate the transmission of coronavirus. And I'm sure everybody in the audience knows about social distancing, and it is indeed the most effective way of reducing transmission. There are other methods as well, including installation of physical barriers and facial coverings in the form of masks. And to the right, I show you a line curve just showing you the impact of social distancing alone in reducing the risk of COVID-19. So if an individual has a risk, say, of nearly 15%, by socially distancing 2 meters, that risk can decrease to about 3%. And if the individual socially distances by 3 meters, the risk is almost down to 1%. So social distancing is a very powerful way of preventing coronavirus transmission. Another method, a little more extreme, is the stay-at-home orders. And this is just showing you in the US the impact of stay-at-home orders in reducing COVID-19 hospitalization. So number of cumulative hospitalizations are plotted on the y-axis and the dates, beginning from March 17th to April 27th. And the black line represents the actual numbers of hospitalizations in Minnesota, and the orange line, the dotted line, represents what would have happened had social distancing and stay-at-home orders not been issued. And you can clearly see a divergence of the curves around 2.5 weeks following the institution or implementation of stay-at-home orders. Clearly a benefit in the right direction for that. And this was replicated in other states, and I give you another one, Virginia, as an example. We've also learned what treatments work and what treatments do not work for COVID-19. We have excellent data that hydroxychloroquine or chloroquine does not work in treating patients with COVID-19 and probably does not work in preventing transmission of COVID-19. What works, though, are these two drugs. One is fairly expensive and the other is very inexpensive. The expensive medication is called remdesivir. It is an antiviral agent that was developed originally to treat Ebola virus, but now has been repurposed for the treatment of COVID-19. And I will show you in the next slide the data that supports its use. On the left is dexamethasone. This drug has been around for 60, 70 years, and it's commonly used to treat individuals with inflammatory conditions. And this has been shown to be highly effective in preventing death from coronavirus. By using this medication, we can reduce mortality by a third in patients with mechanical ventilation, who are on mechanical ventilation. So very, very promising results from United Kingdom. So remdesivir results in 50% faster recovery compared to the use of placebo, and that's shown on the left, if the patients require oxygen. So they're severe enough to require oxygen. However, this drug, the antiviral, does not work very well if the patient is so sick that they have to be on a mechanical ventilation, a machine. So if we go back to our little cartoon about the natural history of COVID-19 from the asymptomatic period to the most critical, then remdesivir is now positioned as treatment in the severe case, but not the critical cases. Dexamethasone is now positioned as treatment in both severe and critical. And combined, it is likely that overall mortality can be reduced by 40% or greater. So let's talk a little bit more about the virus itself, the culprit. And this is coronavirus, SARS-2 virus, that is responsible for COVID-19. And it's like a ball with a snake-like ribbon inside. The ball on the surface has these spike proteins that are used to gain entry into host cells. So once you contact or contract the virus, say in the nose, the virus looks for a receptor. So the virus cannot get into the host unless there is a receptor. So it's a lock and key mechanism. If the virus is the key, then it's looking for the lock. And the lock is called ACE2, and I've highlighted that in red circle here. ACE2 is the receptor that the host has that acts like a lock, and the spike protein of the virus binds to it like a key. And once that binding occurs, then the virus can get into the host cells and then take over the machinery, the DNA machinery of the host to produce more viruses, millions and millions of viruses in those cells. And then the cells are then released, and then the cells then go to the next cell to infect more. And it's an amplification system that starts in the nose and then traverses down into the respiratory tract. And I've labeled all of the anatomical features that contain this entry receptor called ACE2 from the nose, the nasal mucosa, into the airways, which we call bronchus, into the lungs. But other tissues like the heart, kidney, bladder, and liver also contain ACE2. So the virus, in extreme cases, can end up in the heart and cause heart attacks or blood clots or even strokes. So these are uncommon manifestations of COVID-19, but they do happen, particularly in predisposed individuals. So if we look at what we call expression, the concentration of ACE2 receptor from the nose into the lung, there is a gradient. The highest concentration, as shown in these red dots, are in the nose. This is the port of main entry for the virus. And as one goes down into the bronchus and into the lungs, the circles get smaller, meaning that, and this probably explains why only about 20% of COVID-19 patients develop pneumonia. Most, in 80%, the disease terminates in the nose or in the pharynx. So the main point of diagnostic testing is either through nasal swabs or oropharyngeal swabs into the mouth, or saliva, or increasingly sputum. And the reason for that is the biggest burden of the virus are found in these tissues. Another way of understanding whether one was infected with the virus is to do blood testing in the form of serology. And this is to look for antibodies that the host has produced against the virus. And this test is most effective when taken about 2 weeks or later following the infection. So the research, one of the projects that we're engaged in is to develop a more rapid diagnostic test for viral detection. It's called CORA, and we're doing this work in collaboration with investigators at Simon Fraser University and University of British Columbia. And the whole aim is to develop a rapid, inexpensive diagnostics for COVID-19. And why do we need this? Well, the conventional or the current gold standard in testing is to take a nasal swab and extract the RNA or the nucleic acid from the swab, and then put it into this big machine called a thermocycler that is found in many clinical laboratories. And then the nucleic acid undergoes amplification. And if the gene is rapidly amplified, like gene 1 here in the yellow, then it is a positive test indicating that the virus is present. If it's like control, the blue line, then that would be a negative test. Because this depends on a clinical laboratory and because it depends on this thing called thermocycler, it is fairly expensive to perform, anywhere between $50 to $100 per test. And it takes 24 hours at the fastest to get the results back. Most likely you'll get the results in 2 to 3 days. And there's a 10 to 20% false negative rate. So it's not a perfect test, but it is the gold standard for current diagnostics. What we are trying to do is to avoid the use of that big machine called thermocycler. We still have to take a swab, or we can use saliva, whatever contains the virus. We still have to take out the nucleic acid, but that only takes about 15 minutes to do. Once we isolate the nucleic acid, and shown in red, then our device doesn't require a thermocycler. What it does is it has a primer. It has a match key here that can detect this red line and bind it. And then that key is connected to a light bulb called, it's called a fluorophore. And once all of this lines up, then the light bulb will shine. And there will be a detector to detect the light bulb shining. And that will be the readout for a positive test. And I will show you a little bit more in the next couple of slides. It's called the Mango NASBA technology. And it's actually a very cool technology. So there is no thermocycler, there is no amplification involved in this process that requires that big device. This is a prototype of the device we're building, and the scale shows that it's a box about 4 centimeters in width, 4 centimeters in height, and about 9 centimeters in its greatest length. And inside, if you open up the box, you will see these vials that contain, say, the nasal swab from patients and some controls. And there will be an LED that will shine a light to each of these vials. And there will be here a light detector to to identify the vial that lights up and vials that do not. And I'll show you a video of this. So if we are to develop, successfully develop this device, then it will be certainly cheaper. It will be faster because we're not dependent on the thermocycler. At this point, we do not know what our false negative rate will be. So that is currently under development to answer these questions. So hopefully this video will work. So what I'm showing you here is just a prototype. So each vial contains something. So positive control means this has the virus. Culture virus also means it has the virus. This is a patient sample from individual who had COVID-19. Here's a patient sample that is negative. In other words, they didn't have COVID-19. And here's a negative control, no COVID-19 here, or the virus here. And the reaction, this is sped up a little bit. And you can see in the positive control, the culture virus, and in the patient, the solution becomes opaque. Whereas in the patient without the virus or the negative control, it remains transparent. And so there will be a light detector that will be able to quantitate the opaqueness of these reactions. So that's the principle of how this diagnostics would work. And this reaction would take about 5 minutes or less. So, so that's our CORA program that's looking at the molecular diagnostics, hopefully to complement the existing strategies that we have. We do have other programs either underway or about to be launched. As I mentioned, serology is important to understand who had coronavirus in the past and may be immune to getting coronavirus in the future. And so we've launched this AIDS program to randomly sample individuals from the Vancouver area to find out what proportion of Vancouverites have contracted the virus in the past. Sorry, that's called SeroBC. The AIDS program is so not all antibodies that we produce are created equally. So one of the important things about vaccines is that successful vaccines have to induce neutralizing antibodies. That is, antibodies that can kill the virus. And we need a sophisticated instrument to do that. And we are launching this program called AIDS to look at the prevalence of neutralizing antibodies in those who have been previously infected by coronavirus, just to understand what proportion of the population have this kind of antibodies. Details are provided here. In terms of our therapeutics, as I mentioned, globally, there's been tremendous successes in finding new therapeutics for COVID-19, but additional therapeutics are required. And we have what we call disease model systems, where we have cultured epithelial cells or cells from the bronchus. This is the cartoon to the left. This is what it looks like under the microscope on the right. And we can put various medications to see, with the virus, to see whether the medications can prevent the virus from getting into these cells, or in fact, even killing the virus if necessary. And we're testing a variety of medications. We can tell you that hydroxychloroquine does not work, as shown by the clinical trials as well. We are looking at inhaled corticosteroids. These are topical steroids that asthmatics and patients with COPD use, and we're very happy to announce that inhaled corticosteroids prevents viral entry into these cells. So that's very promising as a therapeutic going forward. And then more genomic work, where we're taking gene editing technology, where we can manipulate nucleic acid to and put it into a solution, put it into individuals' nostril to prevent or to directly kill the virus at the port of entry. So this is an exciting work that we're doing in collaboration with investigators at UBC. So I think that's my last slide. I do have a thank you slide, but I gave you a quick overview of the current state of affairs for coronavirus, COVID-19, and I'm happy to entertain any of your questions. And I see John. John.
Good morning, Don. My apologies. Well, no, I clearly I must be getting older because I seem to be technologically handicapped. And anyway, after about 22 attempts, I am now actually online and I am connected with you. And I did hear your presentation, so that part was
okay.
great.
Well, thank you. Thank you for signing on.
Oh, no problem at all. So just for the audience that are online, we have some questions we want to go over with Don. You're more than welcome to, at the bottom of your screen, you can see there's a place to add questions, so please add them and I will deal with them in the time that we have. But I want to maybe start, Don, with this question. Your project is related to coming up with a better and a more effective testing model, and it would appear that testing is increasing around the world, which would, I guess, mathematically, automatically create a higher amount of cases that would be discovered as a result of increased testing. So when you look at the record numbers that occurred on Sunday on a global basis, are you concerned that there is actually an increased impact of the disease itself, or simply a faster recognition of those who have the disease that already did have the disease?
I think the answer is yes to both. I think both things are happening. So I think with better diagnostic or faster deployment of diagnostics, we are detecting more cases in the community, even of asymptomatic individuals. But I think in certain parts of the world, in South America, for instance, or southern states in the US, I think there are truly real cases, severe cases that are also increasing. And I think that's a disconcerting trend.
So I mean, given that the Southern Hemisphere is going through effectively its winter, is this any way for us to get some sense of what a second wave might look like in, let's say, the Northern Hemisphere when late fall, early winter comes to us?
Well, interestingly, southern U.S. is undergoing a heat wave.
Yeah.
And the cases are rapidly rising. So I don't think heat by itself or sunlight by itself will destroy the virus. What's probably happening in those states is because it is so hot outside, people are going indoors and turning on their air conditioning and perhaps not practicing social distancing and other things.
Right. Okay.
I think that's the main culprit for driving transmission rates, whether it's in Canada, US, South America, wherever. I don't think the virus behaves any different in any of those countries.
And the treatments you talked about, I guess it's dexamethasone and remdesivir.
Yeah.
Decivir, yeah. Easy for you to say.
Yeah.
Okay.
It took me 2 months to finally get it down.
Well, are those protocols being globally used, or is this something that tends to be a bit more regional? Is this available all over the world and being used all over the world currently?
So dexamethasone is now being deployed worldwide. So this is a drug that's widely available. It's dirt cheap. It's pennies a dose. And it looks like you only need to use it for about 6 days to get the full benefits. So even third world countries can use these medications. Remdesivir, on the other hand, is much more expensive. It's about $2,000 to $3,000 per dose, and
Whoa.
you need several doses, many doses, for the effect to be shown. And plus, there's limited supply. So, it will not be available, at least not immediately, in developing countries. It is available in limited supply in Canada and the US and in continental Europe.
So the implication of a reduced mortality rate as a result of even these treatments plus increased testing and therefore an increase in the number of cases would suggest that the effective global mortality rate should shrink. Would that be logical to assume?
Yeah, I think so. And plus all the other measures that we've implemented socially.
Right. Okay. So, and I was just reading, somebody sent me this summary that there are 13 clinical trials for COVID vaccine currently going on and 128 preclinical trials. So, I mean, what's your expectation of how this plays out and when we actually get to a point of a viable vaccine?
So I think this is probably the most important question, because I think we'll have a world pre-vaccine and a world post-vaccine. And when that vaccine, the effective vaccine comes, is uncertain. Now, Dr. Fauci from NIH testified in front of the Congress yesterday, and he seemed more optimistic than ever that we would get a vaccine by the end of the year. I think that is still probably being very optimistic, given the track record of successful vaccine development in the past. But I think, this is unprecedented in terms of the number of vaccines that are in clinical trials. And most importantly, 4 of those vaccines are in phase 3 trials. Will be by September, all 4 of them will be in phase 3 trials where it will be either shown conclusively to work or not to work. So I think this is very promising. In animal studies, they seem to work very well without significant side effects. So I'm very bullish about us, the collective us, identifying the right vaccine certainly within the next 12 months.
So, I mean, Don, you would say, generally speaking, that health professionals around the world all have access to the information, the health protocols, the behavioral protocols that really reduce the risk of the disease. And yet, obviously, depending on the country, and even within a particular country, the impact, the differences from one region to another are extraordinary. So how much of what we're seeing here, in your opinion, I don't want to put you on the spot, maybe a little bit, is political versus actually, a health issue or, in theory, a scientific issue?
I think some of it is obviously political. Some of it is cultural. So if you look at countries where they have had the virus but able to contain it very well, I think some lessons are being learned. So for instance, Japan had a bit of a surge. And, I don't know if you've been to Tokyo, it's almost impossible to socially distance, especially in the subways.
Mm-hmm. Right. Yeah.
And so the way they've addressed this is to increase their hygienic efforts and to wear masks ubiquitously. Like wherever people are, you see masks after masks after masks. And they've been able to suppress the pandemic locally. Other countries have taken, slightly different routes. New Zealand and Australia, yes, they've propagated the use of masks, but they also, really were very tough in terms of stay-at-home orders, cut off all travel and so forth. And they have now gone to almost zero incidence rates of COVID-19. So I think these public health measures do work. And, I think we need to be more aggressive in adopting them locally. I think British Columbia, for the most, to give credit where credit is due, I think British Columbia has done reasonably well, but I think we could do better. I think we
So,
should be wearing more masks more often.
so, so this is an interesting question. Then, I mean, Don, do you think that, say, we should continue with a lockdown, or is this an evolutionary outcome that basically we sort of tiptoe through some so-called back to normal environment?
Well, I think lockdown is an extreme form of public health measure to control this virus, and I think that was clearly warranted when the pandemic first hit. Whether it's continued to be warranted, I mean, there are other consequences of lockdown beyond the public health measures or consequences. So I think that needs to be taken into consideration. But I think we should be advocating more strongly for the use of masks and social distancing in our day-to-day life. And I think the Japanese experience has, I think, taught us that even with those measures, without doing the total lockdown, that things can improve quite a bit.
So how do you see that then integrating into the I guess what now becomes a little bit of a movement, the back to work movement, and people getting into their offices or places of work? Do you is this something you see occurring post, if you will, post vaccine in real terms, and it's just going to be very tentative until then?
Yeah, I think so. I think the pre-vaccine era will be what we're seeing now. Maybe 30 to 50% of repatriation of the workforce to their traditional offices. So I think that will happen. But even with repatriation, we should not lose the sight of the fact that the virus is in the community, and that we should be extremely careful about the importance of implementing social distancing and wearing masks. So we can't let our guard down just because the rates have come down and just because the government has said it's okay to go back to work on a limited basis. The virus may be still in your workplace or in this subway that we take or whatever. So I think we have to use extreme caution.
Okay, well, let me go to the questions. We have quite a few now, actually. So the first question, Don, is this. It says, what do we know about the virus rate of mutation and its impact on testing?
That's a good question. I think that's an evolving set of information. Viruses will mutate, there's no doubt. So far, the mutations that they discover have not impacted on any of the viral testing, on the diagnostics or the therapeutics. And it hasn't slowed down any of the vaccine development. So I think the mutation thus far that people have uncovered are relatively minor and unlikely to impact either their transmissibility or the responses to therapeutics or vaccine development.
Okay, so here's another question, and it says, how about hydroxychloroquine in combination with zinc? There were promising results from this, but the zinc combination seems to have been dropped in recent studies.
Well, hydroxychloroquine has been dropped in many, many studies because large clinical trials, phase 3 trials, these are the most robust trials, have shown so far that they do not work. They do not work. They're not particularly harmful, but they do not work. So in the UK, they have a study called Recovery Study. Well over 2,000, 4,000 people were enrolled, and there was like zero benefit for hydroxychloroquine. So I think the consensus now is that hydroxychloroquine or chloroquine, its cousin, does not work. Whether zinc works, probably not.
Okay, and then this follow-up question from one of our listeners is, what exactly is aerosolized?
So aerosolized are small particles that, think of hairspray. That's aerosol. It's relatively small particles that can get into your nose and into the lungs. So big droplets contain water, and the virus is inside the water droplets. So they're fairly big. aerosol is very small and it's just particulate matter, and it may be just the virus itself mixed with dust or a few other things that can be inhaled directly and go into the lungs. So it's think of the hairspray analogy.
It's been a while since I've used any, but okay, thank you. So this next question, I think I might even know the answer to this one. Is it possible to get tested for the COVID-19 antibody without being specifically selected, i.e. as you just simply personally request that you get tested?
Yeah, that's another, I think, important question. Right, we haven't launched this project yet because the antibody kit, there's been some problems with the antibody kit. And so a lot of the prevalence of antibody studies that you have read online or in the newspaper across the world is being questioned because of the accuracy of the antibody testing. So I think more work needs to be done to identify or discover really robust antibody kits that will work.
And just by the way, in talking about the one that you and your team are working on, Don, do you have a timeline for that before you see it being rolled out in any kind of
probably
capacity?
within 3 months. Yeah.
Okay, so before the end of the year.
Yeah, yeah. So we have a kit that we're working on that looks very promising in terms of its accuracy.
Okay, great. This next question says, please comment on mask effectiveness, N95 versus common masks.
So the most important, most effective are the N95 masks. So N95 means that 95% of the inhalable particles are filtered out. So those are the most effective in preventing COVID transmission or catching COVID-19. But those are expensive and they're kind of stuffy to wear all the time. So, I think cloth masks, multi-layered cloth masks are fine. They're reasonably effective. Even surgical masks can be reasonably effective. The key here, though, is there cannot be any significant amount of air leak between the face and the mask. When you put it on, if you see a lot of air sort of going, from the side or on top, that means that the mask is not working. So whether you use a surgical mask, those blue masks, or a cloth mask, or even N95 mask, make sure that there is good seal between your face and the mask so that there is no significant air leak.
Okay, all right, thank you. So next question, when a vaccine is developed, how effective will it be given there are multiple strains of COVID-19? And I know you sort of addressed this, but I guess it does raise an interesting question because there seems to be a new flu vaccine every year. Will there need to be, I guess, a new COVID vaccine every year?
We're going into uncharted territory because this particular coronavirus is new to humans. So we do not know whether from year to year, from decade to decade, whether there will be significant mutation that will require new vaccine development. So that's an unknown question. So far, as I mentioned before, the mutations have been relatively minor, and there's no concern that the vaccines would not work in those viruses.
Okay, so and correct me if I'm wrong, Don, but it seems to me that there was a vaccine developed for SARS just as SARS was actually petering out. But was there some reason why basically it just sort of went away and no longer became the threat it was?
No, we don't know why SARS disappeared from the face of the earth or close to it. There's, really, there's a lot of hypotheses floating around, but really we don't know. The vaccine was, I think, taken up by Merck eventually, but because there were no cases, they could not test the vaccine in human subjects. So the efficacy of that vaccine remains to this day unknown. But having said this, viruses each virus is different, even within the same family. So I don't think we can say, based on the SARS, the original SARS experience, that this particular SARS will go away by itself. And I think the data so far suggests that it probably won't go away by itself. So
Oh,
I think we'll
right. Okay. But
prepare.
connected to that, maybe that then is this that all of these clinical trials going on, uh, vaccines developed for, let's say, the current strain of COVID that exists, and then that strain changes into something else. Does the vaccine that you've been using then become effectively useless, or is at least it's somewhat effective against any mutation going forward?
Yeah. So before I answer that, let me just back up my answer to the previous question a bit. Um, I think the theory about why the original SARS disappeared, the more commonly accepted theory, is that the original SARS was not that infectious, and so it was quite contained in certain regions of the world. And when those regions were able to treat and isolate the virus, then the virus didn't transmit all across the world. This particular SARS strain is about 10 times more infectious than the original SARS. So I think a lot of the experts are not anticipating that this SARS, the SARS-2, will dissipate like SARS-1. So as for the vaccine question, we will have some immunity, even if there is a major shift in the virus. We will have some immunity to it. Whether that immunity will be sufficient to prevent the most severe complication remains to be seen.
Okay, so connected to that then, Don, so this is I'm just rewording a question I'm seeing here. Um, you mentioned earlier that the two treatments that we were looking at, dexamethasone and remdesivir, did I get that right?
Yeah,
Oh,
excellent.
okay.
It only took you 20
Whoa,
minutes.
okay.
Well, that's very good.
And they would reduce mortality by 40%. And let's say we have a vaccine. Is there some way you would measure the difference in effectiveness and say the reduction of mortality between a vaccine approach and simply continually improving the treatment approach, which obviously is having an impact already?
So I think those two paths have to continue in parallel. So we need to continue developing good treatments and obviously develop vaccines. Even with the vaccine deployment, we will probably have some cases of COVID-19 in the community, maybe even severe ones. And so we do need therapeutics to treat those individuals. But what the vaccine will do for sure is reduce the number of cases in the community. And so, and that really depends obviously on the effectiveness of the vaccine and the number of people who are willing to take the vaccine on. But assuming that it's highly effective, and assuming the vast majority of the community takes on the vaccine, then the number should plummet, and eventually, COVID-19 will disappear from the face of the earth.
So really the benefit of the vaccine is really the reduction in the infection rate itself.
Yeah.
Yeah, okay, all right. And
Yeah.
so, all right, so here's a question. Are you saying that if we cannot socially distance 2 meters in a confined space, then the wearing of masks by everyone present will work as well as socially distancing to prevent the spread of COVID? If not as well, then how well does it work?
Well, wearing an effective mask reduces the transmission rate by 80%. So it's highly effective.
Mm-hmm.
Social distancing probably reduces the risk by 90%. So I would encourage everyone to wear a mask, but especially in circumstances where you cannot consistently socially distance, for sure, I think we should be wearing masks under those settings.
Okay. You're not going to want to touch this next one with the 10-foot pole, but I'll ask it anyway. What is your evaluation of the performance of our public health experts at the federal level?
I think for the most part it's been good. I think Canada has done a good job. has it done, best job in the world? That I can't judge, but I think, for being the first time with this virus, I think our responses, both at the federal and provincial and local levels, have been, I think, an A, in my opinion. But that's just an opinion. That's not dogma. Please do not quote me on that.
Does it matter that in Canada, and this is somewhat true in other parts of the world, but it seems almost extreme in Canada, it's something like 75 to 80% of the mortality is actually occurring in say, long-term care homes, which I don't know exactly how the global statistics work, but that does seem excessive to me. What's your thinking on that?
It's not excessive relative to the US, and I think to UK. I mean, it's relative to China, it is, but culturally, it's very different there than it's here. Our most vulnerable population, no doubt, are the elderly. Frail elderly individuals are most vulnerable to the devastating effect of the virus. So we'll continue to have this issue. So we have to be very, very, very vigilant about protecting our senior citizens from this virus.
Would you expect to see significant changes in the way that the compliance and regulatory environment will work in the long-term care environment going forward as a result of this?
I think it has to change. I think, yeah, absolutely. I think, social distancing, hygiene, the fact that care workers are working in multiple long-term care facilities, those things have to change for sure. And have changed, to be fair.
Don, we have time for a couple more questions. Here's one. You mentioned that Sweden is one area where cases have increased recently. Is this due to using a different, more eased model in mitigating the risks from COVID-19 from the onset? In other words, the fact that they were more open as a society?
I think that's the case. I think unlike other Scandinavian countries, they didn't adopt the lockdown model. They had some aspect of social distancing and mask and those things, but they didn't go to that lockdown model. And I think now they're seeing the consequences from that public health decision.
All right, well, we have time for one more question, and this is, I'm gonna be very selfish, it's my question. So, we were just talking about this the other day, but can you maybe walk us through from your personal perspective what your biggest hopes and fears are with respect to where we go from here with COVID-19?
Well, the biggest fear is that, in a couple of months, we'll forget all about the lessons learned from this crisis, that we will, carry on our lives like we did pre-COVID. And I think that would really be devastating because the virus has not disappeared from our community. The hope is that we continue, doing all the measures that we're now used to doing, plus the medical and health communities step up efforts to get a vaccine done, improve therapeutics, and frankly also improve diagnostics, so that individuals don't have to wait 2 or 3 days for the test results. I think the faster we identify infected individuals, the better we are in terms of preventing transmission. So I think all of those areas can be improved upon, and indeed, I think we are working towards that. So I'm very bullish about where we will be in 3 to 6 months.
Well, on that note, I want to thank you, Don. I mean, first off, great presentation, as always. Great to be updated on sort of where exactly things are. I think most of us are overwhelmed with everything we read in the media, and it's just, you need to take things with a grain of salt when you read them. So it's nice to be informed by somebody that really understands what's going on in the environment. So please be sure to come back and join us in 3 months' time when you're your testing is ready, and then you can walk
Yep.
us through what that means and maybe also help it bring us up to date on where we are at that time.
Delighted to do that. And hopefully there'll be some good news on the vaccine front at that time as well.
All right. Well, many thanks, Don, and many thanks to everybody who's joined us, and we will keep you posted as to our next session with Dr. Don Sen. Thank you.